Hello.
Hi.
Hi. Hi.
Sure that where can I change that setting to, like to optimize for videos?
Yeah. So
Yeah,
when
one
you
second.
press the share,
Uh-huh.
when you
So,
press the button for share screen,
Uh-huh.
then a whole option will pop up: share screen, whiteboard, and things. At that time, at the bottom, there is optimize video. Before you press on actually what you want to share,
Mhm.
so just press share screen once.
Yeah, give me 1 second. Actually, I have to pull the pull my talk. 1 second. Okay. No. Share screen, optimize screen to sharing video clips and share. Okay. Looks good.
Okay.
Okay.
Okay. So good morning, everybody. We welcome you to the next edition of Aasef's talk on eye movements. As you know, Aasef is in Cleveland and he's doing tremendous work on eye movements. For him, eye movements are just, he can wake up from sleep and start talking about the nucleus prepositus, hypoglossa, and whatnot. And we had a long discussion at night. So it's when he's explaining things, he explains it so beautifully that today now he's going to talk to, spoke to us about earlier saccades and pursuit and disorders where the eye doesn't move properly. Now, today he's going to talk about disorders of gaze holding and he'll explain you what is the difference. Aasef, over to you.
Thank you, Dr. Kutari. It's a pleasure again to be here and speak with you guys about a topic which is very near and dear to my heart, Jerk Nystagmus. And at one point, or any nystagmus, so to speak, in other words, disorders of gaze holding. And at one point, I mean, gaze holding it's very important. I view this as the following. The quiet eye tells you much more than anything else. All that is quiet, right? So gaze holding is very important. It not only teaches us a lot about the eyes and brain, but it also teaches us about the control of many movement disorders. And at one point, hopefully in future, we'll get to that type of lectures as well. But today, what we are going to talk about is something very simple, very basic, the jerk nystagmus, which we see very frequently in our world. So with some learning objectives, we will talk about some overview of eye movement examination, some basic principles that I learned from my mentors, which turned out to be very useful and very helpful in my career. To recognize some anatomical, physiological, and pathophysiological substrates for certain disorders which affect our steady gaze, in other words, nystagmus, and some recognized type of some common as well as some classic disorders of gaze holding, which may not be so common sometimes. And of course, we will have some brain teasers every now and then about some unique or typical cases to make sure that everyone is alert and watching. So before we start, we want to talk about 4 abnormalities that can affect gaze. And we won't, of course, talk on all about them, but we'll talk about jerk nystagmus today. So the jerk nystagmus is something where your eyes move involuntarily and they are jerky. What happens, it has slow phase and it has fast phase. So if you look at like the movement of the eyes, it moves slowly, and then it makes corrections. So it's like this, and then it corrects. And that's jerk nystagmus. Then we have pendular nystagmus, which is just like a pendulum of a clock, which kind of goes back and forth like that. So it does not have a slow or quick phase. Everything is sort of slow. So it is pendular nystagmus. Then you have square waves, which is also types of saccadic intrusions where your eyes move and then they stay there and then moves back and then moves again and stays there and moves back. And there is intersaccadic interval. As you can see, the eyes move here, then it stays there, then it moves back. So these look like square waves when you plot them on the graph. And that's why they're called square waves. And then there are saccadic oscillations or flutter or obstacles, which are very rapid, jittery eye movements. We will talk about pendular nystagmus, saccadic oscillations or square waves sometimes in future. Today, we are going to focus on jerk nystagmus because that is the most commonly encountered deficits in the gaze holding. So there are certain rules that I learned from my mentor, David Z, here in the black jacket, and John Lee here in the white jacket. So the first of all, we have to make sure that we have put all our act together. We have our basic preliminaries with us. What that means we have to make sure that our patient can see, because if somebody who cannot see, it is literally impossible to check their gaze or to interpret anything out of the gaze. You can look at their gaze, but there's not much you can interpret out of it. Same stands for the fundus. So you have to make sure that their fundus is okay. In other words, they can see. And of course, last but not least, we have to make sure that the lids can stay open. If they cannot keep their lids open, it is very difficult to examine their eye movements, of course, right? And I typically keep this type of card with us, Rosenbaum Pocket Vision Screener. You can use any kind of vision screener just to be sure that patients have good visual acuity. The other very important is you keep the distance, not between you and patient, between the patient and the visual target. Why it is so important? So as you can see here, typically my arrangement in my clinic is patient sits here, I sit somewhere there, and the visual target is a little bit farther away. I typically try to keep it on the wall. I draw a little dot on the wall so that patient can see that. Now, this is very important. I'll tell you why. There are lots of types of nystagmus which get suppressed when patient asks to make convergence, okay? So you have to make sure that your visual target is far enough that patient does not make convergence to look at that visual target. And in order to prevent that, we keep the target far away. Of course, when target is far away, and then when we give the close target with a finger or with some kind of other object, then you can look at even the effect of convergence on gaze holding. So it's very important that your baseline visual target is far away from the patient. I typically use bright object as my visual target. Typically, I like red colored tip of a pen or anything which is red in color. And it should not be very big. I typically like a pen tip like this, but in red in color. Of course, you want to check for the alignment of the eyes, and you have to keep the occluder. The one that I like is the one which is translucent, so that patient cannot look out, but I can still look at what my what patient's eyes are like, how they are misaligned. And a lot of times you may be surprised that patient's eye is looking like this here in this graph. When you occlude that, it moves in. And this is very important to look at the visual alignment, and occlusion is very important, as you will see in one of the videos. And of course, you have to be very mindful of your patient's age. And a lot of us have elderly patients, and sometimes they don't have good enough range of their eye movements, and not because their brain isn't functioning well, just simply because they don't have good volume or some atrophy or some kind of fibrosis inside the globe, and which is preventing their eyes to move around. So their brain may be completely normal. And a lot of times we notice that in upgaze, a lot of elderly people have difficulty in making upgaze. That does not mean that they have devastating disorders like PSP. They are just elderly senior citizens who cannot move their eyes up as normally as younger counterpart. And of course, convergence also is a lot of times deficient in patients as they age. So you have to be very mindful of patients' age when you examine them. Very important to stabilize patient head. In my world, I see a lot of patients with movement disorders, and if they have a tiny bit of tremor, sometimes that can transmit it to the head, or if they have an involuntary head movements, that if head moves all over the place, the eyes are going to evoke VOR, vestibulocular reflex, and that can have non-favorable sometimes interaction with gaze holding or certain forms of gaze. So if you want to really interpret patient's gaze, you have to stabilize their head. And what I do is I ask somebody to hold patient's head like that as I'm looking at patient's head, or eyes. So you have to make sure you stabilize patient's head. It's very important. I can't explain how important it is. Last but not least, when you check for the head impulses, which is like you hold patient's head and you move the head very fast, but it has to be very brief, because if you do very fast movement, but you do big excursion, they may get neck problem, right? So you want to make sure that very brief but very fast excursion, typically less than 10 degrees, but really fast excursion, which is very important as you test vestibulocular reflex. So these are some basic rules. With those rules, I want to get to some basics. So what normally happens? Dr. Kothari and I were talking about some normal interesting analogies. So let's say your eye is looking at position 1, and now you are moving your eye to the position 2, right? So as you are moving from position 1 to position 2, what is happening here is the eyes are not only this lateral rectus, for example, here is contracting, but the medial rectus is actually stretched. So this stretched muscle is going to create an elastic force. Not only the muscle, remember, the eye is in the orbit, which has a very dense, elastic, fibrous tissues. All that tissue is going to be stretched, which is going to pull the eyes back. So what happens, there is going to be a constant pulling force, right? And that pulling force would tend to move the eyes back. So eye would tend to drift back to the center. Which is of course not desirable, right? So when you want to turn your eyes to another location, which is not necessarily in the center, your eyes need to stay there. And that's when the gaze holding mechanism come into the picture. So we think of it as a pulse and step, right? So imagine your brain is a commander, right? And your eye muscle is a dog, right? Now you are telling dog to move, and dog is going to move from one place to the other. Or you tell them to fetch, it's going to move from one place to the other. And then you're going to tell your dog stay, and that dog has to stay there, right? So your fetch or move command to the dog, which is your eye, is a pulse. And a stay command is your step, right? So somehow brain has to put together its act to efficiently convert this pulse to the step. And at the same time, it has to counteract all these resisting dragging force from the orbit. And this mechanism is actually present in the brainstem, believe me or not. And that was elegantly described by my academic grandfather, David Robinson. You can see his picture here. And you can see David Z, who is my academic father, standing right there doing some experiment with David Robinson. What Robinson said, that our brain cells have ability to convert this pulse to step by doing some fancy mathematics, what he called integration, because it's like a calculus. He was an engineer. And he had shown that in the cell. And of course, this is not going to be very clinical video, next video that I'm going to show, a bit different from the topic of current lecture, but I want to show you this. So in this video, what you see dot here is the position of the eye. This is the horizontal and this is vertical. And as eye is moving, you will hear a little bit of a buzz like zzz, and then you will hear like zzz. So zzz, like that. So that zzz, which is like a humming bee, that is going to be your step, which is going to be your converted signal, and little buzz that you will see, which is your pulse. And this is recorded from your brainstem. So this is what happens. This is how your brainstem cells sound like. This is from, of course, from monkeys, but this is how even human brainstem cell sounds like when you move your eyes. So ready to hear that? So if you had noticed in this video, whenever eyes go down, it buzzes larger. When eye goes up, it buzzes less. That means there is a conversion from pulse to step every time the eyes go down. And indeed, this cell was recorded from the monkey's midbrain, where our conversion happens for the vertical eye movements. In the medulla, we have for the horizontal eye movements. Now, this whole mechanism, which is important for conversion from pulse to step, it relies on three important areas of feedback. One is your cerebellum, your vision, and your orbital proprioception. If you have a problem with any of them, you are going to get a devastating problem where your eyes do move. So you do get a pulse, which is fine over here, but you cannot keep up with the step. And this is something which we commonly see in our clinics, what we call gaze evoked nystagmus. So I'm going to show you this video. It is a slow motion video of gaze evoked nystagmus. And what you will see is you will see a little drift and correction. So as patient is looking to the right side, you see that there is a drift which pulls the eyes back to the center, but then it is correcting to stay on the right side. And this is your typical gaze evoked nystagmus that is present, which is right beating when patient is looking to the right side. So there is a slow movement, which is a drift, and there is a fast movement to the right, which is beat when patient is looking to the right side. When the same patient would look to the left, it changes. It will come in a second. So as patient is looking to the left, as you can see, the eyes tend to drift towards the right now. So leftward gaze gives you left beating nystagmus, and rightward gaze gives you right beating nystagmus. And always when beat is to the right, your drifts are to the left. So this is your typical gaze evoked nystagmus. Of course, there are a few characteristics of the gaze evoked nystagmus, and I will outline them. So like you saw in that video, there are slow drifts which pulls the eyes towards the center, right? Then these drifts are always followed by a rapid movement, which are corrective movements, which brings the eyes back to the target. The drifts are minimal at one position. Typically, in most cases, it is at the center, which is null position. And the eye position relative to the null determines how fast would be the drift. And drift direction changes as your eyes move from one side of the null to the other. So when you look to the right, you get right beating nystagmus. When you look to the left, you get left beating nystagmus. When you go back to the center, gaze initially is quiet, but later on, what you see rebound nystagmus. We'll talk about that a little bit later. With that, I want to ask you about something very special, case one. So this is the woman who came with progressive worsening of diplopia and vertigo for about 11 months. I want you to focus on this video. So she has left beating nystagmus.
Look at the target. Look to the left.
But she does not have.
Look to your right.
She's to the right. When she's at.
Look up. Forward.
Left beating nystagmus.
Look at that target there.
The left beating.
Look up.
Left.
Look up and to the left.
And very minimum to none
Look
to the
up
right.
and to the right.
So basically, there was a gaze evoked. In her case, null was shifted.
Forward.
She also had an esotropia. Eyes, the covered eye goes to the
right
nose.
ESO.
So she had esotropia and she had a
Look towards
gaze evoked nystagmus, but it was null was shifted to the right side. And of course, her vertigo was much worse when she would look to the actually left gaze. She had headache and the pressure. Anybody with the diagnosis? This was her MRI like. Any diagnosis here? So she had a Chiari-Ulnar-Chiari malformation, type 1. And the mechanism for her shifted null was because she had asymmetry. So you can see that there was asymmetric involvement of the two sides of the brainstem. So her Chiari malformation was actually coming down and it was touching the brainstem and it was affecting the brainstem unequally on two sides. And since it was affecting unequally on two sides, her null was kind of shifted on one side. It's like a push-pull mechanism. So her push-pull was uneven and it was shifted on one side. So in nutshell, gaze evoked nystagmus, when patient is looking at straight ahead, everything is fine. Eyes are quiet. When patient looks to the left side, you get left beating nystagmus. Right side, you get right beating nystagmus. Something that I did not show, when patient looks down, sometimes you get downbeat. When patient looks up, sometimes you get upbeat. When to the sides, you see the pocket, we call side pocket nystagmus, which is downbeat and left beat, or downbeat and right beat, or upbeat and left beat, or upbeat and right beat. So this is typical characteristics of the gaze evoked nystagmus, which changes its direction based upon the eye in orbit position. Now I want you to characterize this phenomenology. 42-year-old woman who came with progressively increasing falls. When we look at her eyes, I'm going to show you eyes and her gait, both actually. And I want you to see, I want you to focus on the lids and the eyes, because lids are sometimes also very important to tell you which way eyes are moving. Okay. So I'm going to play this.
Look at her finger. Look at the camera. Look at her finger. The camera. My finger.
Down.
Camera.
Coming back.
So she had downbeat nystagmus, she had stiffness, she had appendicular and gait ataxia as she was walking, but her MRI was normal. So she did not have Chiari, of course, or she did not have any cerebellar deficit. When we did the lumbar puncture and serum studies, we found there were increased titer of anti-GAD65 antibodies. So the diagnosis here was increased titer of anti-GAD antibody in patient with stiff person syndrome. We treated with IVIG, which improves her stiffness, but there was unfortunately no change in nystagmus and ataxia. This is my common observation with patients who get antibody-induced nystagmus, for example. If they come in very acute phase, for example, cerebellitis or somebody who paraneoplastic, who robustly acutely comes, and when we give them IVIG, we typically help them. We can improve their nystagmus, we can improve their ataxia. But in unfortunate cases of anti-GAD antibody, who I suspect take some time to come to our clinics, by the time they get to us, it's too late. And their Purkinje cells they take a permanent hit. So it's like what we call a reserve. So there is a stage at which you can help. But beyond that stage, you can go, and this antibody is untreated, then the damage is permanent. In that case, you cannot treat nystagmus and ataxia. And my personal experience is that in paraneoplastic syndromes, we actually respond quite quickly, because that's the way they present, because they're very acute. But in anti-GAD, they are very progressive and very slow. And by the time they come to us, we can improve their stiffness, but not nystagmus. In this patient, I could help her a little bit with giving clonazepam, benzodiazepine. In this case, I did 0.5 milligram TID, but sometimes I have to go up to 1 or even higher doses of benzos. I also had some luck with Keppra, which is levetiracetam, in other patients, or on a very rare occasion, I could give my patients what we call lacosamide, and that also helped with their downbeat nystagmus. Of course, there's not much published on lacosamide. This brings to another interesting case. So this patient was a 57-year-old woman who came in with altered mental status. And when I look at her eyes, I see the following. So again, if you look at the lids here, it gives you a very good clue, which also goes with the eyes. She has a robust downbeat nystagmus of the eyes, and she has a very strong drift upward, right? When she looks up, her eyes are quiet. What happened? We found lymphocytic predominance in her CSF, right? And then we scanned her. So what we are seeing here, this is her flare, and what we are seeing hyperintensity in her temporal lobe. Of course, I'm giving away some diagnosis here, that lymphocytic predominance in CSF, altered mental status, temporal lobe hyperintensities, but we are also seeing some hyperintensity in the floculi here in her MRI. She actually had HSV type 1 encephalitis, which was affecting, of course, her temporal lobe, which we know very well. But in this unusual case, it was also affecting her cerebellar flocculus, causing downbeat nystagmus. We gave her typical treatment, acyclovir, and it helped her. It's extremely rare. There were only 2 cases reported so far. So we reported this patient who had HSV1, and this was back when I was in my training. This is back about 10 years ago, about 2010. And the one before that was in 1983. That was by my mentor, David Z. At that time, they did not have type 1 or 2 classification on labs. So it was only HSV. So my patient was the first HSV type 1 classified. So with all that, we know all these interesting cases where we can tell where downbeat nystagmus is coming from, but in 60% of the cases, downbeat nystagmus still remain idiopathic. We don't know. And we did a little literature search and editorial, and we find out that this blue, which is idiopathic downbeat nystagmus in the pie diagram, which comprises the major part, stroke or drug-induced MS or infection or some other rare conditions, as you can see here, comprise very small component of the downbeat nystagmus. But my colleague, Michael Stroop, not too long ago, in March 2020, published a paper where he took patients with idiopathic downbeat nystagmus and he did genome-wide association study. And what they found that there was an association with fibroblast growth factor 14, of course, which has some role in regulating Purkinje cell firing. So it kind of makes sense with the theory of downbeat nystagmus. But we still, so this is very new, brand new as of last month. We know that some, what we call idiopathic, may have some sort of genome-wide genetic predispositions. I want to go into some mechanism of downbeat and contrast that with our gaze-evoked nystagmus. So as you may remember, in gaze-evoked nystagmus, what happens, you look to the right, the nystagmus is, or you look up, the nystagmus is upbeat, you look down, nystagmus is downbeat. So how downbeat differs from the gaze-evoked? So normally what happens is your cerebellar flocculus sends a negative signal to the superior vestibular nucleus, which then excites via ventral tegmental tract to the superior rectus, right? And then it also excites caudal medulla, and then it inhibits flocculus. This is a normal circuit. Now, when you do not have flocculus, for example, in our patient who had herpes simplex causing her flocculus lesion, in that case, her superior vestibular nucleus remains disinhibited. As a result, ventral tegmental tract send excessive excitatory signals to the superior rectus. So what happens, her eyes are now being pulled always upward. So there will be a bias. Eyes always want to go up because superior rectus is hyperactive. So this is a key differentiation between your gaze evoked and your downbeat. So your eyes are up and then you get corrective downward movement. So this is your mechanism for the downbeat nystagmus in patients who have deficits in flocculus. And it is very nicely reviewed in this paper in Brain by our colleague Pierre Dellasigny and Milia. Now coming down to a very interesting case, a 34-year-old woman who had trigeminal neuralgia, and she came in with real acute onset of imbalance, ataxia, and our GI colleagues found out that she had focal colitis. We found out in her home medications that she was taking carbamazepine. Her MRI was normal, and when I look at her eyes.
Look down. Look up. I mean, look straight.
So she had a downbeat
Look at the camera.
and she had critically high levels of carbamazepine. So in other words, she had carbamazepine toxicity. And basically health carbamazepine, once level normalized, her nystagmus and ataxia both improved. So whenever you have a patient who comes with acute onset of nystagmus or acute onset of ataxia, and if patient is on antiepileptic, it is very important that you check the levels of your antiepileptics because they can very frequently can cause these acute onset of sporadic nystagmus. Two classics. So one patient had downbeat nystagmus only present when she was
Video. Okay, let's do it.
And when they scanned her MRI, she had a tumor in the nodulus. Similar kind of lesions in the nodulus can also cause another classic, which is periodic alternating nystagmus. So you can see in this lady, she has left beating nystagmus in straight ahead. And then the intensity will gradually go up. Then it will reduce. So it is reducing right now. And then it stays quiet, as you can see, and then it will reverse its direction. Now it is right beating. So it is periodically changing the direction, and sometimes take up to 3 to 4 minutes for it to change the direction. So the other take-home message from this type of patients is when you look at somebody's eyes and something changes, when you check it again, you have to look at their gaze for a little bit prolonged period of time, for a few minutes, just to be sure that they don't have periodic alternating nystagmus. And they all suggest a nodulus lesion. I got a very interesting video from Dr. Sudhir Kothari today. He saw a patient who actually came for a referral for BPPV, benign paroxysmal positional vertigo. She was a 45-year-old. She was dizzy. She had epilepsy, which was uncontrolled. So she had to go on real high doses of lamotrigine. And as she was on this high dose, 3 months, she noticed. Dr. you want to say something? Okay.
No,
So,
no, I don't know who, where the sound came.
sorry, never mind. So over 3 months, she had episodic dizziness, vertigo, and oscillopsia and ataxia. It would last for a day sometimes, or up to a few hours sometimes, and then it would go away, almost like paroxysm. So it was very, very interesting and very mysterious. And sometimes these were positional. So Dr. Kothari did video nystagmography, and as you can see here, in this nystagmography that she had quiet eyes, and now I believe she is put in other position, and as she is put in a different position, her nystagmus would come up. So she had positional downbeat nystagmus in lamotrigine toxicity. And again, in these people, if you re-titrate these medications, their nystagmus gets better. So always remember, look at your patient's medication profile when they come with nystagmus. It is just like tremor. You know, somebody with tremor comes up, you look at their medication profile, same rule applies to the nystagmus also. This is again spontaneous nystagmus in anti-epileptic toxicity with lamotrigine. They're far more common in patients who have phenytoin, as you may imagine, and frequently it was described in combination with phenytoin and carbamazepine. My colleague Jorge Cata had a paper or two on that too, and a couple of cases with lamotrigine. So the morale of the story is it's very important to look at their medication profile when you look at acute onset or spontaneous downbeat or isolated nystagmus attacks. So in a nutshell, downbeat nystagmus is a little bit different from your gaze evoked, right? So your eyes are very quiet when you are in the up gaze, right? So it is quiet. And the nystagmus intensity starts increasing. As you can see, this increasing size of the arrow. I have shown, so it beats down, or it beats down into the right or down into the left. And the intensity gets even higher as they go further down. So this is a classic trait of downbeat nystagmus that you see. Now, another interesting case, 80-year-old man with acute onset of vertigo, typically present when he was sleeping on the side of, while he was in the bed. And when I looked at him, when he was upright, he was fine.
Look at my finger. Camera. Camera. Finger. Camera. Finger. Finger. Camera. Finger. Camera. Finger. Camera. Finger.
Now he's
camera.
fine.
Okay.
Now on the left ear down. Sleeping on the left side. And as you can see, there's
Eyes wide open. Okay. Straight.
looking straight and the diagnosis here was lateral canal BPPV. I know you will have a dedicated lecture on BPPV, so I won't talk much about it, but you can sometimes see that in the lateral canal and can present in this way. Briefly to talk about lateral canal BPPV, we have two types, geotropic and where nystagmus beats towards the ground, which is rather more common form. And then second is ageotropic, where nystagmus beats towards the sky. Typically, it follows posterior canal BPPV. So when you do the Apley maneuver for a BPPV, canaloliths then go into the lateral canal, and then you see the consequence of lateral canal BPPV. When it follows the posterior canal BPPV, the barrier is typically where the posterior canal was. And rarely it can be spontaneous. And when it is spontaneous, the barrier is always the ear on the side with a very strong nystagmus. So in this case, it was his left ear.
Aasef, when you're showing a video and if you're making comments at that time, then turn down the volume of the video. Then we can't hear.
Sure, I will. Yeah. So this is another interesting patient that I saw when I was on call. 70-year-old man with acute onset of vertigo. He has profuse hematochezia and hemoglobin dropped down to 9.0. So when I first saw him, the day he came, I saw that he had geotropic horizontal nystagmus, which was worse in the right ear down. And he had right beat plus upbeat nystagmus when he was supine or upright. So he had this stroke. So this type of horizontal nystagmus, which is position dependent, can also present with stroke. And in this case, it was affecting his brainstem and also the nodulus, as you can see here. Very interestingly, when I saw him on day 2, his gaze was normal. So, and of course, here the stroke was not as big. I mean, it was decent, but it was not super big. So the morale is nystagmus from acute stroke, and most of our experiences generally improves within 48 to 72 hours. They sometimes get by this lingering dizziness that then they get for considerably long period of time. And every now and then they come to clinic with a chronic vertigo, and you find that they had a stroke in past. And sometimes they get a typical recrudescence that we see with any regular stroke, that when they get sick or whatnot, their nystagmus comes back, and then it gets resolved again when you treat their physical illness. But acute stroke, typically the nystagmus resolves in acute phases sometime in few days. This was another very interesting patient that I got the video from Dr. Kothari. 82-year-old man, diabetic, hypertensive, acute onset of dizziness with oscillopsia. Clinically, his speech, his blood pressure was normal, but he had a vertical nystagmus and mildly unsteady gait. Now, you have to remember something about differences in symptomatology of vertical nystagmus versus horizontal nystagmus. A lot of times, this vertical nystagmus will present, patients will tell you that they are falling a lot or they are very unsteady, while horizontal nystagmus would be on the side. So it will be like spinning. So they will feel that they are spinning like this, right? But vertical would be more or less like that. So they will feel they are falling or they are unsteady. So this is just like the way the percept of their surrounds is being represented in the brain because of this excessive movements, and it's different, right? And so that's why vertical nystagmus people will typically tell you that they are unsteady, while the others will tell you that they are spinning. So in any case, going back to this case, so there was no history of vomiting, no anorexia, no alcoholism. When we looked at the video, you will see.
Okay, ऊपर देखो.
So what you are seeing here is there is a upbeat nystagmus. So his eyes are drifting down and they are beating up. So this is totally opposite of downbeat nystagmus. This is upbeat nystagmus. Of course, Dr. Kothari got the MRI. It showed some old ischemic lesion, and his posterior fossa was again normal on repeat MRI 48 hours later. But then about 72 hours later, he repeated the MRI, and what we found was he had an infarct into the pontomedullary junction. It was treated with dual antiplatelet and statin, and he had a rapid recovery over next week, very consistent with what we found in my other patient. Now, I have to share with you a very interesting experience that once I had. So I was on call and I see a patient with profuse cerebellar ataxia and nystagmus, and it was phenomenologically, I could easily localize to the wormus, but we got the MRI scan. Our hospital has a very fancy high resolution scanner. So we scan her on a very high resolution scanner, and it was negative diffusion. And 2 days later, we scanned again, negative diffusion. and we had no clue what was going on. Then I transferred her to our main campus hospital, where I wanted neurosurgery to take a look at her, and I wanted more oncology to look at her because I was looking at paraneoplastic. At main campus, they happened to scan her on 1.5 Tesla instead of 3 Tesla. And it turned out that she had diffusion positive. So so I later on I learned from my radiology colleague is that as you increase your Tesla of your MRIs, the diffusion sensitivity goes down. So you can pick up very tiny flare, chronic imaging deficits on your MRI on higher Tesla, but then you miss out on diffusion. While you do 1.5 Tesla, it's totally opposite. So after that, I learned my lesson that if I see something clinically, if it looks like a stroke, if I have 1.5 Tesla MRI, I would do that. Otherwise, I would just treat it like a stroke. Because you know, a lot of times this diffusion can be negative early on our high Tesla scanners, which are now increasingly morely available. So of course, this is the same thing that Dr. Kothari had said about 1/3 case of posterior fossa stroke or small lacunae can be missed even in on 3 Tesla MRI because they are very small. So whenever you clinically suspect it, you treat it like a stroke. And I'm so glad that our philosophy of treatment is same, no matter whether you are in North America or in India, which is quite reassuring because this is exactly the same thing which we do. Now coming down to some mechanisms of upbeat nystagmus, there is a typographic error, error here. So this is again the physiology. Flocculus sends an inhibitory signal to your superior vestibular nucleus, and then it sends excitation through ventral tegmental tract to the superior rectus, right? And then it sends excitation through caudal medulla to your flocculus, which goes inhibition, right? So now, let's say if you have a caudal medullary lesion, like what we had in the patient that Dr. Kothari had, then you are disinhibiting flocculus. So flocculus is hyperactive, and then it is sending excessive inhibitory influence on superior vestibular nucleus. As a result, your ventral tegmental tract is also inhibited, and as a result, your superior rectus is inhibited. Now, what happens when your superior rectus is inhibited? You have excessive drift downwards, right? Because now your inferior rectus is pulling your eyes down, and your eyes are then going to beat up. So what happens in these patients when you have caudal medullary lesion by excessive activity of the flocculus, you are going to see upbeat nystagmus. Now, you can see something similar if you lesion the ventral tegmental tract, right? So if you lesion the ventral tegmental tract, you are cutting down the signal which goes to the superior rectus, and now superior rectus is now totally not working, not excited. As a result, your eyes are going to drift down and you're going to get upbeat nystagmus. So if you get a pontine lesion where ventral tegmental tract is, you will see something similar. So upbeat nystagmus can localize to your medullary junction or to your pontine lesions at both locations. The only way you can put it together is you have to find some corollary clinical finding or look into the MRI. So this brings to a special case, 56-year-old man with a history of acute onset of imbalance and double vision. He had history of diabetes and hypertension. Now, I want you to look at two things. I want you to look at internuclear ophthalmoplegia. So I'm going to mute the volume here. And what you will see, this patient is asked to look at the right side. As he looks at the right side, his right eye is moving, but his left eye is not. Right? And at the same time, he also has subtle upbeat nystagmus. Now, if you look at the left target, his left eye is moving, but his right eye is not moving to the left. So he has wall-eyed bilateral INO with some upbeat nystagmus. As you can look at his lid, he has a very subtle upbeat there. And that upbeat is becoming quite prominent as he's looking up. And down gaze was normal. See, that is quite, it is obvious here. As you can see, as he's looking more up, it is quite prominent. And his vergence was intact. So when we scanned him, he had infarct onto pontomesencephalic junction. So I had 2 such cases, and then we ended up publishing that. And then later on, I saw 3 or 4 more cases where we had upbeat nystagmus, bilateral, wall-eyed bilateral INO wabino, and they had some exotropia. So when you see this ocular misalignment with upbeat nystagmus, with INO, it's a telltale for pontomesencephalic junction lesion. And if somebody does not have some kind of vascular risk factors, and if it happens acutely, then it is stroke, unless you prove it otherwise. And of course, you can also see that quite commonly in patients who have multiple sclerosis. But if patient does not have history of MS, or if you don't see anything else along the lines of MS, and if it's acute onset, then treat it like a stroke. So we treated with the stroke prevention, nystagmus improved within 72 hours, and his diplopia actually improved within a few weeks. So now, when somebody has diplopia, I have a very, very cheap trick. So most of our patients are elderly enough that they have glasses. If they're not, they can get cheap glasses for $1 from a dollar store. What then you do is you put little frosting, like a tape, like a little sellotape or a little frosted tape like that you can get in any stationery place, and you just stick it over here on the glass. And when you do that, it gives you a very, it's cheap, but you can't even tell that. So cosmetically, it is not terrible either. And patients get very, very good subjective benefit. And then once they get better, within a few weeks, they can just rip off the tape and throw it out. And so that way they don't have to spend money on the frosting of glasses. And most of my patients like that. This brings to special case number 6, 72-year-old woman with a progressive imbalance and stiffness. She had a history of type 1 diabetes, independent of head orientation with respect to gravity. So whichever way I move her head, she still had some sort of imbalance, and she had some gaze evoked nystagmus. She had gait and appendicular ataxia and stiffness. And when I look at her eyes, see this upbeat nystagmus there? Again, focus on the eyelids. You will see it much clearer. Over here, you can see that the eyes also. And of course, when she was supine, she did not have any change or in any of the other gaze orientations.
This one highlights the point that sometimes looking at the eyelid makes it easier to look for the vertical nystagmus.
Yes, it is very important. There are 2 things which I pay attention. So for vertical nystagmus, I very closely look at the eyelids because that helps a lot. And I sometimes also look at the blood vessels, especially for the torsional nystagmus, because blood vessels around the eyes and their direction of motion, it helps you a lot. And I will demonstrate that in one of the next future videos. So in this lady, we checked again, we found increased GAD levels. So anti-GAD antibody can also cause upbeat nystagmus. We actually tried to treat her with plasma exchange. Again, we could improve her stiffness, but we did not have much luck for nystagmus or ataxia in her case, just like our other patient. And that stays the same for about 15 other patients who I had with syndrome of anti-GAD antibody. I did not have much luck treating their nystagmus with any of these. I simply have to use some sort of symptomatic therapy with benzodiazepines or something else. So upbeat nystagmus in nutshell, eyes are quiet when patient is looking down in the orbit, and you see the upbeat nystagmus on straight ahead position, and the intensity further increases as the eye in orbit position goes up. Now, I want you to characterize this phenomenology. I know we talked a lot about lids. So what you see in this patient, you are seeing the lid movements, but if you look at carefully, there are no eye movements. She only had lid nystagmus. So she had just lid nystagmus. She did not have any vertical eye nystagmus. So I call it lid nystagmus. It was actually temporally correlated with periodic lateralized epileptiform discharges from her frontal and parietal lobe. So what you're seeing here is EEG. So the red here is the lid EMG. So every time you see this blip, it shows you the lid movement. And over here, you are seeing the periodic lateralized epileptiform discharges coming from her right hemisphere. And every time there is this nystagmus, there is a correlation with the PLED. What that means is that this was actually caused by the PLEDs, which was manifesting in form of lid nystagmus. I actually called it ictal blink because it's actually a blink because it's bilaterally yolk movement of both eyes, and it involves your levator palpebris superioris, which is for the blink, and that's why I call it ictal blink. Now, this is a little bit different than some sort of lid movements that you would see in patients with seizure or generalized seizure, what I call ictal wink. So wink is actually one side. So if you look at like my face, this is wink and this is blink. So when you see one side of the eye, it is your wink. So I want to see you to see this video. This patient has like generalized epilepsy, and then towards the end, you will see the ictal wink, like his left eye would be so right now he's starting to have a seizure, and then as he will turn his head, you will see that. You see the eyes are closed, but it's only on one side. So here you can see it very well. So, so at the end, you see that this eye is only closed. It's like a wink. And I had another video, which I unfortunately was not able to find, but in that case, patient had like constant rhythmic movement of the lid. And you may have seen that in your own practice also, that one side lid also moves. And what we call it ictal wink. So there is ictal blink and ictal wink. Ictal blink is both eyes or both eyelids, and ictal wink is one. And typically ictal blink I saw in this patient with PLEDs, while ictal wink is generally generalized seizure. And it's probably, we don't know actually what is causing ictal wink. And I asked my mentor, Hans Ludersons. One of the theories is that it is just spread of the current, and that causes that. Lid nystagmus is actually not something that we discovered. It is present, we know it for many years, and it was well characterized by my mentor, Bob Daroff. So lid nystagmus in their patient was present along with a bad vermis cerebellar lesion, and it was evoked by the convergence of the eyes movement. So whenever patient converged the eyes, as you can see in this sketch that came from the Daroff's paper, the patient also had vertical lid movement. So it was ocular convergence had a correlation with the lid nystagmus. And it was originally described by somebody called Pick in 1916, and it was called Pick's nystagmus. And Daroff and Pick and all these people, they came up with the explanation. Then they thought that there is an abnormal spread of electrical activity in oculomotor nucleus during these maneuvers cause lid nystagmus. Now I'm going to talk about an interesting case that was not my patient, but it was seen by my mentor, John Lee, and his colleagues, Shirley Ray and Joseph Delmau. The patient had acute onset of vestibular imbalance, 65-year-old woman who actually boarded the plane from somewhere in Europe and then came down to America, and then she was unable to come out of the plane. She had robust acute onset of gait disturbance. Then progressively, she had deficit in short-term memory for about 2 months. She had 10-kilo weight loss. She was depressed and cognitively impaired on exam, and she was falling backward, and she could not walk. So when they examined her, she had prominent upbeat nystagmus, lid nystagmus, and some form of intrusions. And I'm going to play this video with Shirley Ray's commentary on the background, so I will not speak anything.
Just so we can see precisely what is happening here. Okay. We can see the eyes are moving with upbeat nystagmus, and in addition, they are jerking in multi-direction. The patient's lying flat on the floor now, and I just asked her if things are moving. Are they moving? No. No. We're now recording with the patient lying fully on the floor with on the right-hand side. Do you see anything moving? No. No. Well, now we're recording with you lying on the left side, all the way flat on the floor.
So she had geotropic nystagmus, apogeotropic nystagmus. At the same time, she also had bow tie nystagmus. So what happens is there is a quick, slow phase down, and then she has quick phase, which is combined with the horizontal quick phase. So it is oblique like that. Then she has another slow phase, which is down. And then she has another quick phase, which is combined with another horizontal, and it gives you the appearance of bow ties. So the eyes do this, and it looks like a bow tie. So they call it bow tie nystagmus. The investigations were quite interesting. So her brain MRI was unremarkable. So we could not find any evidence or any structural deficit suggestive of acute onset. CSF has lymphocytic pleocytosis and increased IgG levels, so which showed some interesting thing. Abdominal CT showed actually mass in the tail of the pancreas, as you can see here. The biopsy revealed endocrine neoplasm in the pancreas. They did pancreatectomy. There was a well-differentiated, well-circumscribed differentiated endocrine carcinoma was there. It was metastatic to 1 out of 23 lymph node. It was treated with anti-cancer drugs and IVIG, rituximab. The course, she still had impaired cognition, memory, and upbeat nystagmus, but it was its progression got arrested. So that was good part. some reason, I'm having difficulty in playing this video. Okay. Okay, I'll just play it from here. For some reason, I'm not able to. It's not moving. So I'm just going to play video from here. But what I'll just tell you, because I did not have animation here. So basically, this lady had acute onset of vertigo, and she had incidental breast mass. And she had gaze evoked nystagmus, but there was no rebound. So what you see here.
Look at the camera. Pen. Camera. Pen. Keep looking at the pen. Camera. Pen.
So this patient had a
Camera.
very interesting presentation. So she actually came into ED and they were concerned about vestibular neuritis. Of course, it is nowhere close to that. But when they came to see us, it was obvious that it was not vestibular neuritis. She was admitted inpatient in neurology when I was on call. And we saw this gaze evoked nystagmus. And then in passing, she mentioned that while she was taking shower, she felt some kind of a nodule in her breast. So then we got her to get the workup of her breast mass, and she ended up having invasive ductal carcinoma. It was excised, it was treated with chemotherapy, and in fact, her nystagmus improved within a month of that. So again, moral of the story is that paraneoplastic nystagmus that we frequently see, which is also immune, they present very dramatically, very acutely. And if they present so acutely, that antibody does not have enough time to cause the permanent damage to your cerebellar Purkinje neurons. And then you just act on it right away and you can help them and their nystagmus gets better. And you contrast that with anti-GAD antibody, those are like gradually progressive deficits. So by the time these patients start noticing a problem and start to come to the neurologist, it is too late. And by the time we scan, they start having some Purkinje cell loss, and you can't really help them despite you clean up the antibodies. So this is a difference that I have been noticing between paraneoplastic versus anti-GADs. Now, I really hope that this one works. Okay. Okay, so what is the difference between, this is the other patient and this is the regular gaze evoked nystagmus. So what is the difference between the two? So I'm going to explain to you what is the difference, right? So this is typical gaze evoked nystagmus. I think we have a lag on the video.
Yeah, we're not seeing the video start yet.
Yeah, it is. Did it start?
Yes.
Okay. So let me just go back on this video because I want to explain. So this lady has a regular gaze evoked nystagmus. When she looks to the right side, you see the right beating, correct? And when she goes back to straight ahead afterwards, you see the left beating, right? So what we call, there is a rebound. So when it is on the right side, it is right beating. When it goes back to straight, left beating. When left side, it is left beating. And it is very dramatic. When she will go straight, she will have right beating. So typical gaze evoked nystagmus will have on eccentric position, there will be a beat. And when they go back to the center, they will have a rebound nystagmus, as you saw here. This contrasts with the lady with the breast cancer that I just showed. I'm going to play our video again to demonstrate to you that there was no rebound.
Look at the camera. Pen.
So you see there is a right beating here, but there is no rebound. So the difference between the gaze evoked nystagmus in the black and white video and the gaze evoked nystagmus in the colored video is that the colored video did not have rebound. The black and white video, that patient had cerebellar atrophy, which was leading to gaze evoked nystagmus, while the patient on the other side, colored video, she had paraneoplastic, right? So why she did not have rebound? Actually, this case tells us a very interesting phenomenology. So what happens is when you're looking at the center, you don't have gaze evoked nystagmus, right? When the eyes look to the right side, you get the right beat nystagmus, as I'm showing with this arrow, right? Now, when you get this right beating nystagmus, your brain puts together a way to counteract that nystagmus. So what your brain does, it tells your vestibular nucleus to go and generate something to oppose that right beat. So what your vestibular nucleus then does, it generates the leftward bias. So then the right beat then fights with the leftward bias, and they try to cancel out. They try to minimize the deficits because of the gaze evoked nystagmus. Now all of a sudden what happens? Your eyes go back to the center, so your right beat nystagmus is no longer there, but your bias is still present. So in that case, then your eye would start beating to the left side because of that bias that brain had put together in what we call a rebound nystagmus. Now the patient on the right side who had, we think hypothetically, that she had a putative lesion in the vestibular nucleus because of her paraneoplastic antibodies. And since we wiped off that vestibular nucleus, she did not have a capacity to make a rebound. And that's why she had gaze evoked nystagmus, which was very robust, but there was no rebound. And in fact, that was shown in the animal lesion studies. So when you lesion the input to the nucleus, vestibular nucleus, you get rebound. But when you get rid of the nucleus itself in the animals, you don't see rebound. And of course, patient on the left had intact vestibular nucleus, which has an ability to put together this counteracting bias to fight the gaze evoked nystagmus. So that's why they have rebound. So nystagmus once again saved somebody's life. So there was a 45-year-old woman who came with intermittent jitteriness of vision and persistent dizziness. And when we look at her eyes,
Eyes wide open.
so what you're seeing here is she had like jittery movements, but on top of that, she has little torsional nystagmus. And you can see that here. You look at the blood vessels here, you can see them kind of moving like that. And that tells you the direction of torsional nystagmus very well. In people who have light colored eyes, you can also look at the iris pattern. But I can imagine in people with brown eyes, most like myself or many of our Indian people, we can't really see the iris pattern. So what you want to focus on is the blood vessels, and that tells you the torsion direction. So this lady had a seesaw nystagmus and opsoclonus. We'll talk about opsoclonus later on. And seesaw nystagmus is like a torsional nystagmus, but the two sides of the eyes are disconjugate, and it gives you the seesaw direction. She actually had positive ANNA1 antibody for breast cancer. Again, she came with a very robust, dramatic presentation. with this, and we sent out the antibody panel. She was positive. Then we discovered the breast cancer. We treated it, and actually it improved her nystagmus also. And we think it is because of the hyperexcitability of the brainstem neurons, which cause both pendular nystagmus and seesaw nystagmus. And we will talk more details about that in the future. We are almost getting there. This is a special case number 7. So I remember this was like 2 a.m. at midnight. I was a resident on call, and 56-year-old woman coming into the emergency room. She has a history of epilepsy, and she actually had a vagal nerve stimulator, but I think the controller that she had, she put in the washing machine. So she could not do much about anything, and she had breakthrough seizure, and she came in. I evaluated her in her postictal state after the postictal state were over. So she was at her baseline. And what I found, again, focus on her blood vessels. You see that torsional nystagmus, and her eyes are drifting in the clockwise pattern for her. And it is beating in counterclockwise. So it's counterclockwise beating torsional nystagmus, and it was constantly present. When I was talking to her, I also found out that she has coexisting gelastic seizures in addition to generalized tonic-clonic seizures. So she has these laughing spells. When we took a look at her MRI, she had exophytic hypothalamic mass, which was extending to prepontine cistern, abutting the ventral mesencephalon on the left side. So this mesencephalon is the area where your interstitial nucleus of Cajal and RIMLF is, which is the push-pull, which generates a push-pull mechanism for the torsional eye movement between the right and left. And since she had a lesion over here, this side lost the tug war between the two sides. That's why her eyes were always drifting on her opposite side, because it had a more tone. And that's why she had this constant torsional nystagmus. So it's pretty interesting. Now, just going back to the summary, gaze evoked nystagmus, right? There is stable gaze in the center. When they look to the right, they get right beating, left, they get left beating, up, they get up beating, down, they get down beating. And when you look at oblique, you can see the mix of up and down, whichever direction. And this is a quick summary of gaze evoked nystagmus. Right beating nystagmus here when she took to the right. There is a bit of a rebound that you could see there, and then she gets a left beating nystagmus when she's in the left. So this is gaze evoked nystagmus, which contrast very starkly. So you see that upbeat, downbeat, and nothing at gaze evoked. In contrast, for downbeat nystagmus, there is nothing when they are up gaze, but as they look down, they get downbeat, and the intensity of the nystagmus get more as they are further down. And this is, you want to focus on their lids. Also, you can see it very clearly with the eyelash movements that she has a downbeat nystagmus. And upbeat nystagmus, totally opposite of downbeat, right? So there is nothing much at the lower, but as they go up and up, nystagmus gets stronger and stronger. And this is the video from Dr. Kothari where you can see upbeat. And with that, I want to summarize the rules again. Remember the rules of examining gaze. Be sure to have your preliminaries. Keep your distance. Make sure the patient is not converging because it can suppress some nystagmus. Object should be bright. You should check alignment of the eyes. Be mindful of your patient's age. stabilize patient's head, because otherwise it can create problems and you won't be able to assess gaze very clearly. And head impulse should be fast but brief excursions. And with that, I want to thank you.
Thank you, Asif. That was a masterful presentation. It was like a whirlwind tour through gaze disorders. And we have lots of questions, but what I'm going to do is we are already behind time. So what I'm going to do is we'll have, after your next session, maybe we'll collate all the questions and we will have one session maybe, because 15 minutes is not going to be enough for you to answer questions. So we'll have maybe one whole session for an hour where people will ask all sorts of questions, how to have the bright object and where do you keep it? Because even I have a question, like normally I say, look at my nose, look at the finger. So now that is not a distant object. So you are going to explain us how to have that object behind and what exactly to tell. So I don't want you to tell now, because I think you should sleep. It is quite late for you. And we will have a whole set of questions for you in one session with questions.
Yes, I think next time we will have more time because it's going to be more precise talk, I think. Yeah,
yes.
Great.
So thanks a lot, and have a good day, everybody. And good night, Aasef.
Good night.